A quick sip of contaminated water or a bite of exposed street food can introduce microscopic pathogens into your digestive system. These stomach bugs rarely stay confined to the gut. They slip through the intestinal walls and travel upward, invading the tissue of the liver. Once there, the infection multiplies, resulting in a liver abscess. The body triggers a high-grade fever and severe chills, alongside a sudden loss of appetite and rapid weight loss. This specific combination of symptoms separates a standard stomachache from a critical medical emergency requiring immediate triage. Before initiating treatment, doctors must quickly confirm the exact size and location of the hidden pus pocket. The primary imaging tool is a USG abdomen, or an abdominal ultrasound. Seeing the physical structure of the liver through ultrasound waves is the crucial first step to map the infection. This chart reveals two blood markers. First, a complete blood count shows a drastic spike in white blood cells, confirming the immune system's panic response. Shifting the data, a liver function test highlights elevated alkaline phosphatase, a chemical distress signal from the damaged organ. Together, the ultrasound, the CBC, and the LFT serve as a definitive map. They allow doctors to classify the severity of the infection and choose their exact weapons. If the pus pocket is small, the patient can avoid the hospital and be treated at home using a strict regimen of targeted oral pills. The primary antibiotic strike is a 400 mg tablet of metronidazole, taken 3 times a day for a strict 10 to 14-day course. A second medication, Diloxanide Furoate, is added to the regimen. Its specific function is to eradicate the root of the infection entirely, destroying any remaining parasites in the gut. Because these aggressive antibiotics can damage the stomach lining, a 40 mg tablet of pantoprazole is taken on an empty stomach to prevent severe acidity. The Stage 1 protocol relies on a sustained chemical barrage to slowly dissolve the infection while the patient recovers. When the condition is severe or the abscess is too large, the patient must be admitted to the hospital for immediate intravenous intervention. The first critical IV drip is 1 gram of ceftriaxone, commonly known as monosef. It is mixed precisely with 100 milliliters of normal saline and administered over 20 minutes, twice a day. A continuous secondary IV attack follows. A 100 milliliter bottle of metronidazole is given directly into the bloodstream every 8 hours to overwhelm the infection. If the pus balloon is dangerously large, doctors initiate a physical fallback mechanism called aspiration. They insert a needle directly through the skin and into the liver to manually suck the toxic fluid out of the cavity. When chemical treatments are no longer fast enough to prevent a rupture, direct physical extraction of the pus is the only remaining option to save the organ. Following a successful extraction, the infection is fully drained, the bacteria are eradicated, and the liver tissue begins its long process of healing. This entire grueling medical matrix, from severe abdominal pain to needles in the liver, originates from one entirely preventable source: consuming contaminated intake. Strictly avoiding unverified drinking water and exposed outside street food is the required mandate to prevent stomach bugs from ever entering the system. Recognizing the early symptoms, particularly that localized right upper quadrant pain, and maintaining strict dietary hygiene is the absolute best defense against the escalation of a liver abscess.